ये तो काम
ये कर रहा है, मैं इसको करवाता हूँ।
तो बैठे ही करना पड़ेगा, करेगा वो जो करेगा।
बहुत ऑल्सर करके गई हूँ।
तो एक लॉगबुक बनाया,
वही तो नहीं बनाया तो
कैसे बताओगे कितने लोग
बताना भी
लोकल? हाँ लोकल बता रही है।
सर मैं मुंह से नहीं निकालती कि लोकल में गया। मेरे को सर ने बोल के भेजा था कि किसान छिपी किसी को गलती से भी नहीं बोलना, मैंने लोकल में तो उनसे ही
कर ही नहीं रही हो। लोकल
Live link, you just give me the live.
हाँ खाली हो गया, कल लफड़ा पड़ा हुआ पुलिस स्टेशन में, उसको लास्ट मंथ का रेंट भी वापस करना पड़ा, तो एक्चुअली एसएचओ ने बोला कि वापस कर। हाँ
இருக்காப்பா live link இருக்கா?
Hello.
Residence group.
हेलो।
Hello.
हाँ, गुड मॉर्निंग सर।
Morning. Good morning.
वी आर फ्रॉम ऑडिटोरियम सर।
Oh, okay. So, who's going to moderate the session?
सर माई सेल्फ डॉक्टर राजेश एंड डॉक्टर सुशील।
सर
Okay,
वही
Dr.
बात है
Rajesh.
from BH.
So, we're going to start the dissection. So, first of all, we'll be doing the endoscopic sinus surgery dissection, followed by skull base. So, who are all the dissectors here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 dissectors. Okay, good. Ready? Yeah? Skull stores. Where's skull stores? Skull stores. Please come. Get me the camera. Telescope. I need the skull stores and metronic to be washed up. Put in a gloves and come.
2015 में नहीं 15 मैंने तो बीएचयू ज्वाइन किया
0 degree.
एक विषय तो रेजिडेंट है ना। हाँ हाँ तो वो कराना गलत
Yeah.
तो वहाँ जाके कोई बोले अरे अभी हो जाएगा करवाना है ना डिस्ट्रिक्ट। बहुत सारे सीनियर लोग आ रहे हैं, सबकी वाइफ आ रही है। हाँ तो कोई दिक्कत नहीं, पत्नी को जानती तो बोले कि नहीं मिलना है, नहीं तो सिर्फ घर ले उसको बोला ना कर दे। शिकर है
Okay, is the picture seen there? This is the endoscopic picture. Oh, the scope is broken. The 0 degree scope is broken. You can see here. There's a little dark shade there. You have a new scope? The moment you see all this, you have to, because they'll say I broke it. That's the problem. See, if you get some black fibers like this, always examine the scope. See that 4 o'clock, 5 o'clock position. You see here? So that's broken scope. So as you know, whenever we do endoscopic sinus surgery, my only scope I use is 0 degree and 70 degree. I don't use any other scope. Of course, if you want, you can use a 30 degree, but most of the surgery is done with a 0 degree telescope. Remember this. So 0 is, you know the color code, right? 0 is green, and then 30 is red, 70 is yellow, 45 is black, 90 is blue. So you know all that. So let me check whether this scope is okay. This scope is better. Thank you. Now, Blackatli, Soumya, no. We never use Tilly's forceps. Many people they use Tilly's. I never use Tilly's forceps. Never in my because I don't use any forceps which opens proximally. Everything should be opening distally. So that's a fairly large. Okay, that's it. Okay, this side has septal deviation. Okay, right. So I'm going to start my either. Did you get the link? Where's the link? Okay, ready. So endoscopic sinus surgery. So first of all, I'm sure that you would have all read my 15 commandments. Have you read my 15 commandments? How many have you read? No, the dissector. So whenever you come to dissect, do a little homework and come. There's no point just coming point blank. You should read my 15 commandments. How to hold the scope. The scope is held like a flute. Never hold the camera. Never hold it like a dagger. And whenever you introduce the endoscope, you should introduce it along the ala. This is the ala. And your instrument goes along the floor. This is the floor. So you, at no point this should cross over like this. The instrument should never be above the endoscope. The distance between the endoscope and the instrument should be around 1.5 centimeters. Your left hand and the right hand should be in synchrony. Okay. So now many people talk about the Stamberger's 3 passes. Pass 1, pass 2, pass 3, but I have combined all the passes, if you have read my book, into one pass which is called the aircraft technique. So you can see here, I start like this. This is the aircraft. So see here, this is the aircraft. The aircraft starts moving, that's the runway. See, moves, and then what you're seeing here is the inferior turbinate. You don't have to see the nasolacrimal duct and all in every case. And then see how my hand moves up. So my hand moves up to see the axilla of the middle meatus. So this is the axilla of the middle meatus, this one here. So that's where the middle turbinate originates from. If you're not able to see this, that means there is a huge septal body. For example, in this side, you see here, you can't see the axilla. This needs a septal correction. If you want to do a fist on this side, it needs a septal correction. Why? Why? It is not because you're not able to see it, but maybe you will push it and do it out. Post-operative follow-up for the front sinus will be difficult. So it's only also for intraoperative management as well as post-operative care. So you see axilla, you see the middle turbinate, and of course the middle turbinate is being pushed because of the gauze piece. See how gently you just push it here. So you are able to see the uncinate. This is the maxillary line. This is the maxillary line, and you are able to see the free border of the uncinate process. Here, this is the hiatus semilunaris inferioris, and that's the hiatus semilunaris superioris. Hiatus means door. Door opens into room. So this door hiatus similaris inferioris is a door which opens into which room? Infundibulum. And this is a door, hiatus similaris superioris, which opens into the room called the retrobulbar and the suprabulbar recess. Okay, so the room is the retro and the suprabulbar recess. That's the bulla. And when you go here, this is the middle turbinate. That's the sagittal attachment of the middle turbinate. So the middle turbinate has got various attachments. That's the coronal attachment of the middle turbinate, and that's the horizontal attachment of the middle turbinate. So here is where you have the Sphenopalatine artery here. Okay. Now you see like this. You go like this. The aircraft technique. 1, 2, 3, 4, and then see like this. I mean, of course, it will be like this because, yeah, 5, 6, and then fly between the middle turbinate and the inferior turbinate. 1, 2, 3, 4, and then dive into the nasopharynx. Now here is where the flight lands. When the flight lands, you are able to see the eustachian tube. You know. So this is what you are doing in your cadaver first. Do the aircraft technique, and when you practice the aircraft technique, you start doing it very fast. Very fast means you see here. So I practiced this a lot when I was a PG. See here, 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Of course, in this cadaver you have a little, but in live you should be able to do 60 times. 60 times in 1 minute, 60 times in 1 minute, 60 times in 1 minute. Chuck, 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 chuck. You should be able to do. This is the first practice I give you. Okay. So you have done the aircraft technique. The next step is, in all test cases, what you do is you should never block the choana. Never block the choana, because if you block the choana, many people keep merosil, all that inside the choana. Never do that, because you're creating a choanal banking effect. Don't create a choanal banking effect. You want that choana to be free because the blood goes inside. And the first step is to lateralize this inferior turbinate. How do you lateralize the inferior turbinate? Don't lateralize like this. Go back, and then see here, I use the belly, this belly. And then when you lateralize it during surgery, you should not have even one RBC. See here. 1, 2, 3, 4, 5. Okay. So this is how you lateralize the inferior turbinate. Again, I say 1, 2, 3. Here you can give a little pressure. See what happens when I give the little pressure. This Uncinate process in a live, it moves medially. That is why we give this pressure. Get my point? It is not only to create room here. See how the Uncinate process. See the Uncinate process moving. Can you see? So in a live, when you move like this, that will come like this. So you want the middle, the Uncinate process to get medialized. That's why you do that. Okay. Having done that, see, if you have a middle turbinate like this in live, it's called paradoxical middle turbinate, right? So how do you deal with it? If I do like this, it will go back. If I do like this, it will go back. I'll give you a trick. Give me a small gauze piece. How many minutes do I have? It's already 9:30. My time is up. Another 6 minutes. Shall I finish? When should I finish? No, what time you have given me, boss? Tell me. So 9:30 to 10:30. Good. Huh? Okay, so what I'm going to do is to just continue for the sake of dissectors here, and they will be projecting it in the second hall, so we can go. So I can tell you a lot of points. So of course I'll finish it by 1 hour. Break a sleep, please. Quick. Debrider connection. So see what I do here. See here. See this. This is what you do in live as well. You take adrenaline pack, adrenaline, pure adrenaline, 1 in 1,000 adrenaline, and then keep a gauze like this. See here. And then what you do is you just introduce this gauze piece behind. See here. Gently. All this should be like a painting. Picasso painting. Should be here. See. Now, as I do behind, what I do here is I compress the Sphenopalatine foramen. See here, I am compressing the Sphenopalatine foramen. At the same time, I am causing massive hemostasis. But what has happened here? It has moved. See that? It's moved. Can you see the point or not? So this is what you should do. You should go on forcing, it will not come. So keep a small, nice adherence of gauze piece nicely here. You press it here. Once you press it, what happens? You get hemostasis. And at the same time, what happens to the middle turbinate? Okay, right? So you got this point. I'm sure many of you might not be doing this. That's why I'm telling you here. Some people, what they do is they resect the middle turbinate. Don't do that. Don't resect the middle turbinate. Okay. Now, the next step is uncinatomy. Give me the backbiter. Generally, I don't use the ostrums. You have a Nagashima. Okay. See here. If it is like this, you have different kinds of backbiters. One is left backbiting, right backbiting, but better to get a up backbiting. But here, what you should do is when you see my body position like this, and then I move towards the body like this. So I turn like this, and then this is my elbow. I move my elbow away. See the very important position here. Many people do like this, wrong. So this way, and then introduce it like this. See here, and then direct it upwards. See here, 1, 2, 3, 4, 5, 6, 7, 8. When I'm in 8, I am in the front of Bullae. Then see here, see my elbow position. 1, 2, 3, 4. See what I did. See how much of lateral my elbow is. This is the base of the next triangle. I can actually do like this and then that's it. Now 1, 2, you have to cut till the maxillary line. 1, 2, 3, 4. That's it. Finished. See that? All like a painting you should do, my dear friend. Get my point or not? So again, I repeat. When you're doing uncinectomy, body, elbow. Go inside. Go like this. In your mind, tell 1, 2, 3, 4, 5, 6, 7, 8. Go, open, then cut. You understand? Now, this is the first step of uncinectomy. The second step of uncinectomy is take a ball probe. Maxillary ball probe. Now see here. This is the ball probe. Okay, this is the maxillary sinus ball probe. You have various kinds of ball probes. This tip can be directed 90 degree, can be directed 60 degree, can be directed 45 degree. Better get a 60 degree ball probe. This is 60 degree. See, 60 degree. Whenever you choose instrument, you should be very careful. Simply don't get a ball probe. You should get a 60 degree ball probe. See, again, body position, elbow position, and then 1, 2, 3, 4. See here. 1, 2, 3, 4. 1, 2, 3, 4. What am I doing? I'm actually converting the sagittal attachment of the uncinate into a coronal attachment. You get my point or not? See, it was like this. I made it like this. Get my point? Now give me the debrider. So step number 2 is making the uncinate coronal. Step number 3. Step number 3, use a RAT 12 debrider blade. RAT 12. This is not a RAT 0, it's a RAT 12. See here again. See here. 1, 2, 3, 4. See here. How I move my debrider blade. 1, 2, 3, 4. 5, 6. That's all. You don't have to go very high. I'm just taking off this inferior part of the uncinate process. Get my point or not? And once I see here, what will happen is the first step is to look for the natural ostium. This is the commonest mistake I've seen in all the pest surgeons. Give me a ball probe. Now see the next fourth step. No, put the ball probe. Now see again the 60-degree ball probe. And then you see here, I'm now going to gently tease this Uncinate process. See, I'm teasing the Uncinate. I'm using a 0-degree telescope. Now, can you see the infundibulum, my dear friends? All of you can see the infundibulum there? Yes or no? Now,
Yes, sir.
you can use a 30, that's why I said I can use a 30-degree telescope. See here. 30-degree telescope. So here you can use a 30, but generally in live, you will see it. In a cadaver, it's slightly lateralized. So use a 30-degree telescope. And what you see here is the natural ostium of the maxillary sinus.
Right.
See here. The 30-degree telescope. Can you all appreciate the natural ostium? Yes or no? Now, you do what is called the hanging technique. Have you heard me telling this? So, how do you do the hanging technique? This should have a 90-degree ball probe, not 60-degree. So, that is also not there. So, see the instrumentation. So, for the fourth step, you need a 90-degree ball probe. You see how I do that? See here, I go like this. I'm using a 30-degree telescope here. I go inside, I need a 90-degree anyway. And see here, the movement is I go down and like this. So this is the horizontal part of the Uncinate process. You can see horizontal part. See how beautiful the horizontal part is. So it has got two attachments. Hello? Somebody
Yes, sir.
is talking.
Yes, sir.
Yes, sir. Yes, sir.
We are getting the picture, sir.
See, this is the lacrimal attachment, this is the turbinate attachment of the horizontal part of the Uncinate process. You can actually beautifully dissect this. See, how many people dissect this like this? See here. See that? So this is the orientation of the lower part of the Uncinate. Always it will be like a U. You have one attachment in front, one attachment behind. So this Uncinate goes behind. You see here. This Uncinate goes behind. See. So sometimes if you don't have a posterior fontanelle, this goes and gets attached to the palatine bone. See. See how beautiful. Actually, you should enjoy this section. See. So you can actually take this out. This is the horizontal attachment of the Uncinate process, horizontal part. See here. So this whole thing is the horizontal part of the Uncinate process. Can you see or not, my dear friends?
Yes, sir. Yes, sir. We can see.
See, gently go there like a tiger's cub. And then I'm going here again, the beautiful cadaver. Thanks to anatomy department, HOD and also the associate professors. Sorry. Actually, I don't wear my shoes when I do my dissection. I treat it like God. Now, you can see here, I'm going inside. And where is the natural ostium? Here. Can you see? See, you go down. I hang. It's hanging. And then I go behind. See here. So, one, actually, little orthotic. 1, 2. So, L-shape movement. Hang, back. Hang, back. You get my point or not, my dear friend?
Yes, sir. Yes, sir.
Here. This is called the hanging technique. This also I have only described. When you hang, very important that this mucosa should not come down. So you should be very careful that this mucosa doesn't come down. You should reposition that mucosa. You get my point now? All of you? A little
Yes,
bit
sir.
of the inferior turbinate is here. How beautiful this fest can be. Okay, right. Now that's the middle meatal antrostomy. Either you can take it to the bleckosty, or you can take it to the debrider. Usually in live, I take it to the debrider. Here I am just using a bleckosty process. See, I don't want to shear that superior mucosa. That's why I'm coming from inferior to superior. But sometimes it's so rubbery. That is why debrider is better. No, 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 don't worry. They will understand. So see that rubbery mucosa. You see, maxillary sinus. This should not happen, but I'm just in cadaver it happens because it's thickened. No, naturally. Okay. Now, having done that, if you do like this in live, what will happen? If you do like this in live, you will have what is called missed ostial syndrome, MOS. So don't do that. It will close the natural ostium. This mucosa will go close the natural ostium. Can you see here, my dear friends?
Yes,
Can you see
sir.
a bulge there?
Beautifully.
Can you see the bulge behind that in the 9, 10 o'clock, the 10 o'clock, 11 o'clock position? That's the intraorbital
Yes,
nerve.
sir. Right problem now.
Yes, sir.
Okay, that's the intraorbital nerve. Right. So we have finished what? We have finished middle meatal antrostomy. This is a type 2 antrostomy. Okay. Theory and all I'm not talking now. The next step, what I should do, there's a lot of water there. I'm not able to stand properly. Okay, I want a cloth. So see here, I've left behind this part of the uncinate process. Can you all see that?
Yes, sir.
Now, what you should not do, is don't take an upturned Blackesley forceps and bite it. Never do that. Why? If you do that, give me a cloth here, please. Yeah, keep it. Thank you so much. Thank you so much. Why? Because your upper attachment of the uncinate is like God. It's like God. Why? That only gives you an idea of where the frontal recess open. You get my point? Now see here. It's straight. It's okay. See what I do. See the movement. Movement is from anterior to posterior. See here, my dear friends. Anterior to posterior. See how I'm moving. So always use a debrider here. My dear friends, use a debrider here. Wow, what a beauty. What you're seeing here is nothing but the recessus terminalis. What is recessus terminalis? The recessus terminalis is nothing but, so you can call it the Aganati also. Some people call it the Aganati, some people call it recessus terminalis, whatever. See, nothing. This uncinate process was attached like this. This is the part of the uncinate process going towards the lamina papyracea. The lamina papyracea, it forms a blind pouch. This blind pouch is nothing but recessus terminalis. See, I'm just taking off that mucosa alone. See, no, that in live you don't have to do that, but I'm just showing you how this mucosa can be reflected like this. Now, having done that, this is the upper attachment of the uncinate process. Can you see that, my dear friends?
Yes, sir.
Or no?
Yes, sir.
Now, if I push the upper attachment of the uncinate process here, if I push the upper attachment of the uncinate process, give me a 70 degree. Now, in all frontal recess surgery, we use a 70 degree. Okay, so I push the Aganasi or whatever you call. I'll just take a debrider. I'll just remove that mucosa. And once I remove that mucosa, this mucosa also can be removed. Now you can see here with a 70 degree, I'm going to use my 70 degree. Behind the Aganasi, you will find the frontal recess. In front of the bulla. This is called bulla up technique. See here, I'm just going to show you. See how beautiful. See the frontal there. Can you all see that?
Yes, sir. Yes, sir. Yes,
So
sir.
there's one cell here. That one cell. It could be the interfrontal cell, but that's the frontal. Okay, and see how beautiful it looks. Now you have another important thing called the frontal ball probe. This is the frontal ball probe. All of you get this instrument. Okay, this is very, very important. Same way you have 60 degree in it, you have 90 degree in it, you have a curved edge in it. Three kinds of frontal ball probe. Get a 60 degree and also get a 90 degree. So these two are important. These are all instrumentations you should always have for frontal surgery. See here. Now I'm just going to make this mucosa here like this. It's like corneal surgery, boy. It's a beauty, you know. Cadaver is so good. See here. See the frontal. Can you all see the frontal?
Yes, sir. Yes, sir. We can see it.
You can see the Friedman sign here. So you can see. Can you see? Come and see. No, it's okay. So इसमें नहीं दिखेगा क्योंकि वो cadaver है ना. पर यहाँ दिख रहा है, थोड़ा दिख रहा है ना. So that's the Friedman sign. If the Friedman sign is positive, then you open the frontal. Now, if the mucosa all around the frontal orifice is healthy, don't go and put the debrider inside. Don't do that. If you do that, you will lead to iatrogenic frontal stenosis. Now, the next step is the Bullae. Right. This is the Bullae up technique. The reason why we do the Bullae up technique is some people are scared of the anterior artery. If you are scared of the anterior artery, better to do the Bullae up technique. The broken one, don't give no, take it off. Right. Now, how do we do the Bullae? There are various methods of doing the Bullae. One is the centrifugal approach to the Bullae. Second is called the centripetal approach to the Bullae. I'll show you what is the centripetal because most of you might not have even heard of that. Doctor, give me an elevator. So, Filippo does that. See here. He is from Brazil. You can see here. You can go here and start operating on the Bullae. If you have an inverted papilloma here, you can start operating on the Bullae like this, slowly. But you should be very careful about lamina papilla. That is why doing a centripetal approach for the Bullae is a little dangerous unless you have, see the lamina papilla. Can you see here? So here, this is what is called the centripetal approach to the Bullae. Many people would not have seen it. That's why I'm doing it. So you can take that inverted papilloma in toto. Many people teach you, you go like this, right? That is the centrifugal approach. Okay, that is the centrifugal approach. See, there's an attachment of the Bullae to the middle turbinate. So see here.
Yes, sir.
So that's the attachment of the Bullae to the middle turbinate. In a centripetal approach, what will happen is you can remove the Bullae in one piece. The Bullae in one piece you can remove. That is the advantage of centripetal approach. So if you have an inverted papilloma, if you have a tumor, you can remove this Bullae in one piece. See how beautiful that is. That's the basal lamella. You can see here. That's the basal lamella.
Yes, sir.
Now give me a scissors. So the first time I think you are all seeing what is called the centripetal approach, but don't follow it unless you are very experienced. So you just have to cut it like this. You have to cut it like this. See what happened? I removed the Bullae in one piece, boss. Here. Most of you have been taught centrifugal approach to the Bullae. But here in tumors, what I do is a centripetal approach. See how beautiful it is.
Sir, any advantage of one approach over the other?
You see, if you go centripetal, you have margins for the tumor, right?
Yes, sir.
Just that advantage. Apart from that, there is not massive. See. This is the Bullae in one piece. So you can mark lateral margin, medial margin, superior margin, inferior margin. You have a tumor here sitting right on the Bullae. So that's the advantage. Okay. Now, but you guys, if you follow the centrifugal approach, go through the Bullae. And how do you do the Bullae? You have to go antero-inferior from here. You understand, my dear friends?
Yes,
now,
sir.
when you have done the Bullae, what should be the end point of that Bullae removal? What should be the end point of that Bullae removal? I want to show you again with a 70-degree telescope. So, this is what is called the anterior ethmoidectomy and frontal sinusotomy. So, when I say, hey guys, do anterior ethmoidectomy with frontal sinusotomy, this should be the end point. I'll show you the end point. These are all very, very important points, my dear friend. Unless you are master in this, you can't go to skull base at all. See here. Now I'm going here. Give me a J curate. Now, why? So this is the wrong instrument. Give me a ball probe. Give me a ball probe.
Sir, some surgeons use maxillectomy to expose the frontal disease area, sir. Maxillectomy to.
Axillectomy.
Yes, sir.
You mean the axillary flap approach?
Yes, sir.
Yes, sir.
You can whatever you want, you can do both. Ultimately, you should be able to convincingly open all these sinuses. You can do. It's just mucosa thing is not catching. So this is the end point of your anterior ethmoidectomy. What are you seeing here? Ball probe. What are you seeing here? See here, nicely, my dear friend. Very, very important, my dear friends. See here, the first what you are seeing is the nasofrontal beak. This is the nasofrontal beak. Nasofrontal beak. See, this thick bone. Behind will be the frontal recess. Can you see the frontal recess here, my dear friend?
Yes.
And this one here, just behind that, is the anterior fovea. Anterior
Yes,
fovea. So the frontal recess extends anteriorly from the nasofrontal beak till the posterior end of the anterior fovea, which is formed by the anterior ethmoidal artery. So this is the anterior ethmoidal artery. See here, this is the anterior ethmoidal artery. Can you all see that? Anterior
Yes, sir.
ethmoidal artery goes from posterior to anterior, lateral to medial. Oblique, runs oblique. Can you see, my dear friends?
Yes,
Clearly
sir.
seen or not? See, Jason, can you see?
Yes, sir. We can see it.
This is anterior fovea. This is the frontal. So frontal recess from nasofrontal beak to the anterior ethmoidal artery. Medially from the laterally from the lamina papyracea till the middle turbinate. Can you all see that clearly, my dear friend?
Yes, sir.
Super, super. Right. Now, this is the, so behind what you are seeing, behind the anterior ethmoidal artery, there is a big plate of bone. This is the basal lamella. Middle turbinate curving laterally and getting attached to the lamina papyracea. Right. Okay. Now, I will tell you an easy technique, which I have described. No, 30 degrees. 0 degree. Easy technique for the posterior point. Easy technique. Gospel. So this, I think they are published with a Russian girl called Syria. So you see here, take this. See how I'm holding it. I'm holding it like this. See nicely, I'm holding it. Okay. Okay. Now I'm keeping this like this. And see here, this is the floor. This is the middle turbinate, right? Just go above the middle turbinate and keep this gauze. With the gauze, you know that's the skull base. Go parallel to the middle turbinate. Parallel to the middle turbinate. See, parallel to the middle turbinate, and from here you go up like this. Like this. Don't force it. Then your movement should be like a cross. 1, 2, 3, 4. 1, 2, 3, 4. Understand? So again I say you go here. Don't go like this. If you go like this, you penetrate the skull base. With the gauze piece only you should do. Gently. 1, 2, 3, 4. 1, 2, 3, 4. So we have done that, and once you do that, you will see what a beautiful, fantastic view of the posterior ethmoid. You take off the gauze. Once you take off the gauze, what happens? You are able to beautifully see the posterior ethmoidal cell. Can you all appreciate it, my dear friends?
Yes, sir. Yes, sir. We can appreciate it.
So this is what is called the gauze piece technique. See the posterior skull base. See, that's the posterior fovea. Anything behind the anterior ethmoidal artery is called the posterior fovea. So if you are experienced, use your debrider. If you are not experienced, don't use your debrider. Don't use your Blackesley. Best is gospel. Okay. Can you see the skull base very beautifully now, all of you?
Yes, sir. Yes, sir. We can see it.
Now, the next step, very, very important step, my dear friend. Now, give me a ball probe. See here. This is what is called the baby walk. How does a baby walk? Walks like this, no? Walks like this, no? Okay, I'm going to show you exactly the same walk. So, where do you start walking? See here. This is the middle turbinate. This is the maxilla. So, the baby starts walking exactly at this level. 1, 2, 3, 4. See, baby fell down. Baby fell down. See here. Again, 1, 2, 3, 4. Buck. Baby fell down. When it falls down, nothing. You see here. This is your forceps. Just tilt it like this. See the movement. Like that. Gentle, not too much. Huh? Gently tilt like this. See here. Now, again, baby walk. 1, 2, 3, 4. Buck. Fell down. Gentle. Gentle movement. So, what do you see here? Ah, superior turbinate. Beautifully seen superior turbinate. So what is this called? This is nothing but the superior meatal window. Get my point? Hello?
Yes, sir. Yes, sir.
See how beautiful it is. Now, once you do that, take your debrider. You can do that with the debrider also. You do what is called Jula technique. So I taught you 2 words now. One is the baby walk. Second is called the Jula. What is Jula? Swing, right?
Right.
How do we go by swing? Like this, right? So you swing between the lamina papyracea and the middle turbinate. Your debrider should be directed downwards. See here. Downwards. See here. Now, this is the Jula. This is the lamina papyracea. This is the middle turbinate. Block my suction outside. Hey, suction on man. क्या क्यों ऑफ कर दिया यार? मैंने पूरा नहीं किया अभी तक. See here. ब्लॉक डाला. Wama, metronic. No, this one is blade is blocked. Clean it, clean it. हाँ उसमें क्लीन करो ना. जल्दी जल्दी करो. I have only 7 minutes more to complete the press. After that, so usually a total sphenoethmodectomy, maxillary and prostomy from sinus should take 20 minutes only. More than 20 minutes you should not do. See here. I started at 9:30. See, this is a Jula technique. So it's working properly. What happened to you? Suction work. தண்ணில வச்சு கொடு. சத்தம் வரவே இல்லையே. अरे मेट्रॉनिक कहाँ है यार? करो यार प्लीज. Please help. I'll tell you. Now this is the Jula technique. Jula technique. See here. Okay, I have removed that mucosa. पहले अच्छा कर रहा था, क्या हुआ? Tubular technique.
So yeah,
Now, once you do that, take your Freer's elevator. Freer's elevator. Now, see here, what you do with your Freer. See, properly see here. This is the middle turbinate. You don't go like this. You will enter into skull base. Gently push the middle turbinate laterally. Can you see, my dear friends?
yes, sir, we can see.
What you are seeing medially? What you are seeing medially is the septum. Okay, that's the superior turbinate.
Yes, sir.
Pushing the superior turbinate. And what I have to see,
Sphenoid sinus ostium.
see the sphenoid ostium there, my dear friend.
Yes, sir.
Suction दो भाई. Suction लेकर दो, तो निकालो. Through biting करो. Can you see the sphenoid, my dear friends, all of you?
Yes, sir.
Now,
We can see it.
see the sphenoid. Take a through biting. See here. Take a through biting like this. See my elbow position, please. See here. You cut the inferior part of the superior turbinate. Don't cut the superior part because it contains olfaction. You understand?
Yes, sir.
Okay. Having done that, I have removed the inferior part of the superior turbinate. And what are we seeing? We are seeing the sphenoid os. See
Yes,
here.
sir.
Just
Yes,
going
sir.
to put it inside and gently open it. Gently open it. This is what is called the Parson's ridge. This ridge separates the sphenoid sinus from the posterior
Ethmoids.
ethmoid. Okay.
Yes, sir.
So that's the sphenoid sinus. Can you all appreciate the sphenoid sinus, my
Yes,
dear
sir. We
friends?
can appreciate it.
So that's it. Now, if you want to see the interior of the sphenoid sinus, you have to remove the mucosa. So he's got fungus. What is this? Maybe he died of let us liquid. So that's unhealthy mucosa of the sphenoid sinus. Now see here, I'm going to take off that mucosa. He's got some polyp. I wish I had operated on this patient when he was alive. All polyp. So you can see here that I have removed the polypoidal mucosa from the looks like a schwannoma. Ready? Yeah. So that's the sphenoid sinus, my dear friend.
Yes, sir. Yes, sir. We can see it.
And you always widen it towards the planum. Working. Okay, finished. Now what you're seeing here is the intrasphenoidal septum on the right side. I'm going to, this is the finished. That's all. Fest is over. I just want to
Yes,
show
sir.
you some landmarks. See here, this is the carotid artery here. This is the carotid
Yes, sir.
artery here. That's the optic nerve. Can you see the optic nerve? Whitish optic nerve, all of you?
Yes, sir. Yes, sir. We can see.
Carotid, the lateral opticocarotid recess is not very clearly seen, but that's the optic, that's the carotid. This is the posterior model nerve and artery. This is the planum sphenoidale. This
Yes,
is
sir.
the posterior model nerve and artery. You have olfactory filaments here. Posterior fovea is all posterior fovea between the posterior ethmoidal artery and the anterior ethmoidal artery. Posterior fovea. This is the anterior ethmoidal artery. The anterior
Yes, sir.
fovea. This is the frontal recess. So that's the end of pest, my dear friends. So easy, you see. See, when you look at it, it looks so beautiful. There is no stalactites, stalagmites. You can remove all that. So that's it. So easy. So if you do the pest like this, then very less chance of recurrence. Of course, you get recurrence, but very less. Don't remove middle turbinate. This, that. Wrong. So this is how it should look. The cavity. 1, 2, 3, 4. See, at one go with a 0 degree, I'm seeing the maxilla, I'm seeing the sphenoid, I'm seeing the frontal. That's it. With a 0, see how beautiful it is. This is all you have to do in your cadaver. I'm going to show you 2 other exercises now. Give me an elevator. Now, I'll show you how to do a Sphenopalatine artery ligation. See here. Now, this is the inferior turbinate, posterior end of the inferior turbinate, and this is the
Yes,
posterior border of the maxillary sinus. Now, give me a
Yes,
sickle
sir.
knife. What you do in case of Sphenopalatine artery ligation, you see that's the incision tube. Now, I'm going to use a sickle knife now. Make your incision above the level of the posterior end of the inferior turbinate. See, I'm making a horizontal incision. See, I'm making a horizontal that should go anterior to the basal lamina. Get my point, my dear friends. So this is a
Yes,
horizontal
sir.
incision. Then in live, of course, you would not have done a middle meatal antrostomy. So I'm making a vertical incision like this. This is a vertical incision. Now you can use whatever instrument you want. You can use a foblation, and then you start elevating. The moment you start elevating, you will see a bulge of the bone. So that bulge is called the crista ethmoidale. Called crista ethmoidale. Can you see the Sphenopalatine artery, my dear friends? Can you all
Yes,
see
sir.
that clearly?
Yes,
So
sir.
that's the crista ethmoidale. This is Sphenopalatine artery. See, it took hardly 1.5 minutes. Not even 1.5 minutes. You have to give what is called the Stamberger's middle turbinate maneuver. Just push the middle turbinate medially, and you will see the Sphenopalatine artery. Okay, so again I repeat, make an incision along the posterior border of the upper border of the middle inferior turbinate, make a vertical incision, start elevating like this, and push the middle turbinate medially. You will stretch the Sphenopalatine artery. You can clip it here. Don't use unipolar, you can use bipolar. So that is about Sphenopalatine artery. Now the next step you can do is a DCR. Now I'll show you how to do a DCR. So DCR, you would have read my technique. So I generally don't practice the incision of Professor PJ or mold. So you see here, I do an inferiorly based flap. This was published by us in the British Journal. Dr. Neeraj Suri. She is a very good cochlear implant surgeon now, but she came for a fellowship to me, and at that time she published. Very good surgeon. So you see here, I am making a inferiorly based flap. Can you see here, my dear friends? Yes or no? See here. So that is the inferiorly based flap. I will just push it inferior. That's it, finished. Once I push it inferiorly, like this, I will start my, so till what I push that flap, I push it at the level of the superior border of the inferior turbinate. See, now this is the ascending process of maxilla, this is the lacrimal bone. Now give me a punch. Now use the upturn punch. See here. Now see here. See my hand. Not this punch. Normal punch you don't have. This should not be there. Just see. Now go along the inferior border and see how I'm leaning on that patient. See how I'm leaning on that patient. This is very, very important, my dear friend. And then what you do is I am just going here. I'm making that first bite and then the second bite. That's it. Now clean this. So you see, I've made that bite. That's the nasal lacrimal duct. Now what I will do is my car will turn upwards. See here. My car is turning upwards. When I turn upward, I move that. I hold it and gently take off the scope. You might break the scope. See that? Now, having done that, you see how much of bone you have removed, or you can punch also. See how nicely you are able to punch all that bone. Better to use a punch, don't use a drill. Get my point? So that's the sac. I can see the sac very beautifully. See, this bone superiorly should go, boss, because the common canaliculus, the fundus of the sac is far above the axilla. It's around 1 centimeter above the axilla. See here. See. Okay. Having removed all that bone now, okay, now Soumya is going to give me a pressure here. Now give me a sickle knife. So there are two layers of the sac. One is the endosteal layer, and second is the see. Can you see here, my dear friends? So I'm going to scrape this endosteal layer here. You can see that's the endothelial layer. It's blue. Whitish is the endosteal layer. See, you can remove that endosteal layer beautifully because endosteum supplies blood supply, so you don't want it to come back. So these are all the research, and we did the publication. We were the first in the world to tell about this. The recurrence rate is 6% higher. See, that is the endothelial layer. Now I'm opening the sac. Now you can make a beautiful cut. See that? See how beautifully the sac is open. Can you all appreciate it, my dear friends? So this is the upper. See, that's the common canaliculus here. See the valve here. See here. See. Beautifully see. Okay, this can be a flap, and then you reposition this flap on this bone. So you don't expose raw. Now you see, you should
Hello.
see that.
Dissection all.
Hello.
You
can cut a little bit of it. Okay, right. Now the next which I'm going to show you through biting is the orbital decompression on the optic nerve through biting. Optic nerve decompression. See how fast you can actually demonstrate. It's very easy, boss. Everything can be demonstrated in less than 1 hour. Come on, block more. Suction. Suction. Come on. Now the next step which I'm going to do for you guys is the orbital decompression on the optic nerve decompression. This is the DCR, taking off the posterior flap of the sac. Can you all see that clear, my dear friends?
Yes, sir.
How nice it looks. Very important. So the common canaliculus also. Of course, in live we don't bite the sac like this. Okay. Now the next step which I'm going to show you is the orbital decompression, optic nerve decompression. Give me the stylus. Blackasly. Now see, before you do orbital orbital decompression, you should do an optic nerve decompression. So the first is optic nerve, then only comes the orbital decompression. Why? Because if you do the orbital decompression, the fat will come off. The fat comes off, you cannot see the optic nerve. Get my point? See, that's the
Yes,
optic
sir.
nerve. Can you see here? Give me the stylus drill. See here, this is the stylus drill. Use the diamond drill. Okay, ready? Put that drill on. Metronic, please. Center, yeah? Okay. No. See what you do here. I'm using a stylus drill, of course. Don't use this force cutting burr. So this is the always go along the length of the optic nerve. Can you see here?
Yes,
My
sir.
dear friend, doing it slowly so that you will see. So the optic nerve, see here, before it goes intracranial, has got a course in the sphenoid sinus. This is the course of the optic nerve in the sphenoid sinus, the level of the optic tubercle. So this is a very common surgery we do for bony tumors engulfing the optic nerve or trauma. No, you don't have suction. No, what you will do? I'll take a little time, but I single-handed. Usually I do 400. That's why Soumya is asking me, shall I come that side? So these are all 400 techniques. Okay, suction. So I think I've done my decompression. You should always irrigate a lot to decompress the optic nerve. Can you see the optic nerve, my dear friends, there?
Yes, sir.
The whitish optic nerve. Can you see? It's clear, right?
Yes,
So
sir.
whenever you have the optic nerve exposed, the sheath exposed, what you have to do is to make an incision on the right side. On the right side, you make it from 12 to 3. On the left side, it is from 9 to 12. Very, very important, my dear friends. You do that only when you have a hematoma. Or else you don't need to. See here, I'm incising the sheath. See here. Can you see here? This is 12, this is 3.
Yes, sir.
Can you see, my dear friends? This is the
Yes, sir.
optic nerve decompression. Finished. You do that also for BAH, like optic nerve fenestration, all this stuff. Now, after doing it, you are doing an orbital decompression. How are you doing it? See here. Again, this is the DCR. Behind the DCR, start removing the lamina papyracea. This is the lamina papyracea. See here. Can you see, my dear friends?
Yes, sir.
See, that is the periorbita being exposed. That is the periorbita. You always combine it with the optic tubercle. I'll show you the optic tubercle. See here. See, that's the level of the optic tubercle. See. The fibers are from up to down. See, like this. Okay. That's the optic tubercle. You have combined the orbital decompression with the optic nerve decompression. Can you all see that? You
Yes,
have to
sir.
leave behind 5 millimeters of the bone superiorly. You have to leave behind 5 millimeters of the bone superiorly. You get my point? So here,
Yes, sir.
what we will do is we'll make 2 incisions on the periorbita. See, give me a sickle knife. All of you see this very carefully. Where I am making the incision. See here. Don't go posteriorly and make the incision. Make an incision anteriorly and inferiorly. Like this, because the muscles are 1.5 centimeters away. After that, you hook the periorbital like this. Hook the periorbital like this. See. You see, you have to hook it. You go deep, you will hurt the muscle, the patient will develop diplopia. What is the condition for which you do it? You do it for Graves' ophthalmopathy. You do it for any tumors. See, you just have to just extend it like this. Above. Now press the orbit. Press the orbit. See. Can you see that clearly, my dear friends? Now,
Yes,
the
sir.
moment you take out the fat, you will see the first muscle. You will see that. I'll show you the muscle. See, can you see that muscle here?
Yes,
Hello?
sir. Yes, sir.
This is the medial rectus. Can you see the medial rectus here?
Yes,
Yes,
sir.
sir.
Yes, sir.
Now, here, if you go down, you will see another muscle, which is the inferior rectus. I'll show you that. You want me to stop the dissection? You tell me. I think I've already got a call to stop it. I can go for 3 full days for dissection work. You guys will get bored. Now, here is the medial rectus. See the another muscle here.
Yes, sir.
Can you see the muscle there?
Yes, sir.
This is inferior rectus. This is medial rectus. Now, when I take this fat above, what muscle will I see here? Huh? Superior oblique. See the another muscle you can see above the medial rectus here. Till here is the medial rectus, and you see that muscle above is the superior oblique. Okay, so superior oblique, medial rectus, inferior rectus. So we have done the orbit, we have done the fess, we have done Sphenopalatine artery ligation, we have done DCR. So this is all expected out of most of you in your dissection specimen. So I am through. That's all. So you want some more, or I just finish it now? Organizers, Shiva, Dr. Shiva.
Sir, audience in the auditorium want medial maxillectomy to be shown.
No, the thing is, I mean, my time is up, boss.
Sir, can you show us the V2, V3?
V2, V3. Boss, that and all will take some time for us. I have to drill a lot for that. I am ready to show anything you want. You have to give me time. No, 1 hour mein kya karenge? Okay, I'll just show you medial maxillectomy alone. So give me a scissors. So for medial maxillectomy, the first step, I'll do a septal correction pause. Useful for you. See, always septal correction is here. Always make the so you have you all read that article on Royal Pearl technique of septal correction? I don't know whether you're read, but please, if you're not, yeah. So read that article which has been published by Dr. Uday Chanukya. So we make the incision in the skin. See here, this is the skin. See, make a vertical incision on the skin. These are all very useful for PGs. So the first step is to make the incision like this on the deviated side. So now there is nothing like SMR, septoplasty, there's nothing like that. Now it is endoscopic septal correction. Usko hi, that is why I did this. No problem. See here, my first movement in my septal correction is like this, backward. Like this, backward. And then what happens is my movement becomes up, down. There are 2 kinds of movements. So posteriorly as you go, your movement is away. Like this. how beautiful septal correction looks. Ah,
Portrait करने के लिए कौन-कौन क्या
बढ़िया।
करना है फोटो?
அப்போ ஹாலில் யாரும் இருக்க மாட்டாங்க, தப்பா நினைப்பாங்கண்ணா. சொன்னா கேளுங்க. ஒரேஷன் போது இருக்கக்கூடாது. புஷ்டா அந்த மாதிரி பண்ணக்கூடாது. That will lead to a bad. I'll finish off in 10 minutes. ஏன்னா அப்புறம் ஹாலில் யாரும் இல்லைன்னா அவங்க தப்பா நினைப்பாங்க. So you see here, see the movement. This is what the movement. So again I tell you, when you make the incision, the first movement is like this, the second movement is like this, third movement is like this. You understand? See, these are all movements you should learn, my dear friends. See how beautiful it looks. Now, what you do is, it's a slightly three-handed technique. We ask the assistant to put the small number 1 suction tip. You should get a number 1 suction tip and put it like this. Put it like this. Then make the incision here. Wherever the deviation, you make the incision. You don't have to completely remove the septum. Endoscopic septal correction is all about removal of just the deviation. In this, you have a gross deviation on the left side. So see how I made that incision. Always slice that and see what is the movement here. See here. You have to go like this. See how nicely we got it. Here the movement straight away is up down. Now you see, within a minute I have got it now. Now again the movement here is away, like a dosa. How many people make dosa in the house? Ladies will do beautifully septal correction. See. Coming like absolute dosa. See here. See how nice. This is olfactory. Okay. Now having done that, you can resect whatever part of the septum you want. So this is a bony cartilaginous junction here. So you can actually make the incision like this along the bony cartilaginous junction. Scissors, please. Now take a turbinectomy scissors. You can replace that septum if you want. You can replace this septum. See, this cartilage. Some people use that for the spur cartilage, for reconstruction, for middle ear and all they use. Put it in 100% alcohol. Give me a scissors now. Never use lux forceps for septal correction. Many people use lux. Don't use lux. If you use lux, you are a barbaric surgeon. This is okay. See, use this instrument. This is, what is the name of the scissors? Mayo scissors. Use the Mayo scissors. You'll have a little marrow. See the marrow there. See cholesterol. Wow. Enjoy all this work. Now, this is a perpendicular plate of ethmoid. Can you see? Now, once you do that, I have almost completed it. Now, I'll show you how to elevator. Now, you see this side. See, I opened up the axilla. It was not open, no. Now, you have a little bit more of deviation. See here, this one, this part. Scissors, please. So elevate properly, then only use the scissors, or else you will cause a tear. Understand? Now give me the scissors, the Mayo. Whenever you do perpendicular plate of ethmoid, always use a Mayo scissors. See how I'm using it? Super. Now, having done that, see how beautiful it is now. This is how you do it. Okay. So it's very simple. Now, come on,
Sir.
Okay. Right. Now, what I will do now is I'm going to show you a modified endoscopic denture. This is one of the common surgeries performed in ENT now, apart from medial maxillectomy. So first I'll show the medial maxillectomy, then I'll show the endoscopic modified dentures. Of course, I can show pituitary and all, but it might not be, time is not enough. Scissors. So the first step you do, all take a photo. Now see here. Now see how I'm holding. See, it's not like this, not like this way you hold it, and you keep it obliquely, not like this, obliquely. See here, 1, 2, 3, 4. See here, you keep it obliquely and then cut. Once you cut and
Endoscopic.
cut. Hello?
Yes, sir. Yes, sir. We are with you, sir.
See. Now here you will have one branch of the Sphenopalatine artery, which is the middle turbinate branch of the Sphenopalatine artery. It will bleed. During surgery, it will bleed. You have to have a cobblator. Now, I really thank the anatomy department for this wonderful cadaver. Wonderful cadaver. Who is the HOD who is here? I saw associate professor. Really, I should thank them for. Wonderful cadaver. Very rare to get such a cadaver. Now you see here, this patient has got an inverted papilloma. You don't have to resect the inferior turbinate completely. Elevator. See, I'll show you how to do a medial maxillectomy. You have to resect the middle turbinate because you have to get a complete. See here, this is the nasal lacrimal duct. Now you start elevating the mucosa of the inferior turbinate. See here. See. Now what you can do is you can resect it from here to here. Yes, scissors. Scissors. Don't have a terminal scissors. Terminal scissors. Yeah. Scissors will cut at the tip. You should always go posterior to the nasal lacrimal duct in a medial maxillary. My dear friends, you should go posterior to the. Give me a backbiter now. See, nothing but you're widening the maxillary sinus ostium till the floor. That is medial maxillectomy. At that time, you're cutting part of the inferior turbinate, you're cutting the middle turbinate apart, and you see here, I'm just going to take off all this. Now you can use the debrider. You can use the coblation in a live patient. You can use the coblation. See how I'm doing it now. See, you don't have to resect it completely. Debrider model. Now you see, my dear friends, somebody asked for medial maxillectomy. Hey. Press, my dear. Can you see how big the maxillary sinus ostium has become, my dear friends? At the same time, I am not cut the inferior turbinate completely. Note the point, my dear friend. You can cut the inferior turbinate if you want, but I have not done it. See, the inferior turbinate still little bit is remaining. Only the middle part of the inferior backbite again. Only the middle part has been cut. See here. Thing is not catching. Now, can you see, my dear friends, how big you made the ostium? Take a sleep, please. Anybody has got any doubts in medial maxillary? I can see the floor of the maxillary sinus also here. This is a 0-degree view. My dear friends, it's not an angle view. It's a, with a 0-degree, I'm seeing it. That means the 45 or 70 degree, I'll be seeing the whole maxilla. Give me a backbiter. Backbiter. I'm just going to take off only this part of the bone. That's it. Super. Give me now the 45 or 70 or take from there the whole panoramic view. I'll put it in my biodata. So, photo. Okay, ready. Right, see here. See. Medial maxillectomy, end of medial maxillectomy. See. Can you see, my dear friends? So, whatever you have, big attachment, inverted papilloma and all, you can remove. But the problem here is I'm not able to see the alveolar recess. So, to see the alveolar recess, it's always better to do a endoscopic modified Denker's or a pre-lacrimal approach. Of course, now I can't show you the pre-lacrimal because I've already done a nasolacrimal duct dissection. So I'm going to cut off this inferior turbinate. See, results. I'm cutting off the inferior. See here, my dear friends. See, I'm cutting off the inferior turbinate. This is the first step in a modified endoscopic Denker's approach. Can you see here, my dear friends? Now give. Now once I do that, give me a knife. See, the next step is to make an incision anterior to the anterior pyriform aperture. See here. I'm just palpating. See, 1, 2, 3, 4. See? 1, 2, 3, 4. See that? Then I make an incision there. Get my point? So you should see the slip. 1, 2, 3. 1, 2, 3. 1, 2, 3, 4. 1, 2. See that? Can you see? I made that incision anterior to the anterior elevator. Now, having done that, what you do is first you take off this mucosa out. So this mucosa is medial along the inferior meatus. Can you see, my dear friend? See here. Give me black asleep. So many things we can show, but the thing is only the time. If you give me one day, I will train you in everything and form. Elevator. Now see here, you have to elevate along the anterior pyriform aperture. As you elevate, the first structure you see here, I'll show you that, is, see here. See, that's the infraorbital nerve. Can you see the nerve here? Nerve bundle, can you see or not? Nobody from the auditorium. Okay. So this is the superior boundary of the endoscopic modified Denker. Now what I will do is I'm going to take the drill. Silence. Now see here, my dear friends, usually I ask Soumya to elevate. It's okay. So first you open up the maxilla. I've gone into the maxilla. First I went into the maxilla and then do like this, do like this. Superior osteotomy, inferior osteotomy. You understand? See here. I'm going now. See, I went inside. Can you see that hole? You put your drill inside and then come out. Not this way. Okay, it's called nudging. I call it nudging. See here. See, I go inside. See, I'm just nudging. Can you see, my dear friend? Of course, if she holds it, will be better. But okay, it's okay. So this is what is called the superior osteotomy. இது போடுமா suction போடுமா suction போடுறா. Okay, so I made my superior osteotomy. See, can you see the superior osteotomy, all of you, my dear friends? Yes or no? Now I have to make the inferior osteotomy. If I hold like this, it will be very good. Okay. வேணாம் சரி பிடிக்கிறியா? So I will just do the inferior osteotomy. Good. This is what we do in most of the JNAs, inverted papillomas, if it's involving the alveolary. Okay, finish. That's all. 2 minutes what? Endoscopic center. What is there? Nothing is there. Everything is so easy. You're all skull-based surgeons now. One day you became skull-based surgeon. Yeah. See. Can you see the maxilla? Straight end-on view of the maxilla. Now what you do? This is a nasal lacrimal duct here. I've already opened. I have to cut the nasal lacrimal duct. Give me a scissors. Mayo scissors. You break. The mayo one வாங்கிக்கலாம். யார் கொடுத்தது? யாரு? மேயோ நம்மளுக்கு ரொம்ப கஷ்டம். Can you see, my dear friends? My dear friends, I am removing the medial wall of the maxillary sinus. Boss, this is the commonest surgery. Please, you learn this surgery very well. All the juniors, when you're doing cadaver dissection, please do this surgery, because this is the future. Most of the cases you will be demanded to do this case. Now, once you do here, what are you seeing here? My dear friends, this is the posterior wall of the maxillary sinus. This is the palatine bone. Okay. Now what I will do is I will drill. This is the intraorbital nerve. See. Can you see the intraorbital nerve? You saw anteriorly also, here also you are seeing. Now make that drill. I'll show you how to drill. Very, very important. You make again 3 osteotomies. Superior osteotomy, lateral osteotomy, inferior osteotomy. Same like this. See here. This is superior osteotomy. This is intraorbital nerve. Don't go here and do it. Inferior to the this part of the bone will be like slightly thicker. This part of the bone will be slightly thinner. This is lateral osteotomy, my dear friend. Inferior osteotomy. As we go medially, the perpendicular plate of palatine bone suction becomes slightly curved. Okay. Now, have you seen the osteotomy? 3 osteotomy. The level of osteotomy, lateral osteotomy, depends upon the size of the tumor. If the tumor is going very much into the cheek, you go far laterally. If it is not going, you don't need to do. So, see here. Okay. Now, having done that, give me elevator, cat's paw. Now, the best instrument here is the cat's paw. See, it's called the cat's paw. You don't have a back of the prears. You have something like this, no? Have you seen that? That is called the cat's paw. Okay, show. You have to use the cat's paw. See. came out. Little bit here. Need the cap. Okay. Can you see that infratemporal fossa? All of you, give me tuck tuck. I'll remove that bone. Beautiful, beautiful. Ah. Tuck tuck. Slowly. Tuck tuck. Enough. Tuck tuck. Here you can have some bleeding because of the tuck tuck. Yes. Because of the descending palatine artery, which is the terminal branch of the internal maxillary artery. Okay. See. What is this? Anybody? I'll give you one gold medal if you say this. This one. What is this? The orbital process of the palatine bone with the sphenoidal process of the palatine bone. Nobody is getting gold medal here. That forms the Sphenopalatine foramen. Okay. Now see here, beautifully seen. Now where do you look for the internal maxillary artery? See here, this is the infraorbital nerve. Just below it, just below the infraorbital nerve, you look for the internal maxillary artery. See the Paul probe. See here. See. This is the infraorbital. Can you all see the infraorbital nerve here? Just go here and tease it here. The periosteum. Okay, my dear friends. See, I'm removing the periosteum. Can you see? What are you seeing here? See, my dear friends, what are you seeing here? Beautifully, you are seeing the artery. That is the internal maxillary artery. Okay. Now, this internal maxillary artery, you see here, I don't know if you can imagine a little bit. See here, it's giving off one branch here. I don't know if you can see this branch. This is the infraorbital artery. And when I pull it, there's one branch which goes here and one branch is coming down here. I'll just pull it and show you. See, this is the Sphenopalatine. This is the descending palatine. So this is how you clip it. Get my point? You have a clip or scissors, give me a scissors. I'm going to cut it. Don't do it live. Don't say Janakiram cut it, so I'm cutting it. I'm not responsible, doctor, professors here. So I'm going to cut it here, but in live you have to clip. See the lumen. See. Wow. See how beautiful the lumen. Now this is Sphenopalatine artery. I'm going to cut the Sphenopalatine artery here. See the lumen of the Sphenopalatine artery here. You see. Now I'll cut the descending palatine artery and show you the lumen. Everything is mathematics, box. See, this is the lumen of the descending palatine artery. You can see descending palatine, Sphenopalatine, internal maxillary. Wow. See how beautiful it is. It's all. Give. Like a sleep. I'll remove that complex internal maxillary, Sphenopalatine artery, descending palatine artery complex. I'll remove. So, if you draw a line from here downwards, medial to it is the pterygopalatine fossa. Lateral to it is the infratemporal fossa. And what is this area called? This area is nothing but the pterygomaxillary fissure. Okay. Now what I will do is, give me a debrider. I'm going to debride the medial aspect. What will be behind it? Behind it will be the pterygoid wedge. Behind it will be the pterygoid. See here. So I'm just taking this out. This is IMAX. In life, if you do this, no, believe me, the patient will die on table. Hey, don't do this. Tomorrow your professor should not say, guy, taught wrongly and went away. Okay, why it's not working? Let's sleep. Now, I saw something whitish here. Did you see? That is the pterygoid wedge. How is the pterygoid wedge formed? It is formed by the joining of the medial pterygoid plate with the lateral pterygoid plate. The medial pterygoid, lateral pterygoid, they join and they form a quadrangular bone, and that gets attached to the base of the sphenoid sinus. Get my point or not? This is the pterygoid wedge. You keep your finger here. Here. This one will be the median nerve, the pterygoid wedge. Keep another finger there. Here. Two fingers. One is median nerve. Keep one finger here. This is the V2, foramen rotundum. Keep another finger down. Here, you keep Here. See. This is at 60 degrees. This is the palatovaginal canal. Palatovaginal canal, where it transmits the pharyngeal nerve, which is the branch of the pterygopalatine ganglion. This is the median nerve. This is the V2, which is the maxillary division of trigeminal. All of you remember this, boss. It's at the level of 60 degrees. You can see these three structures: palatovaginal canal, median canal, foramen rotundum. Everybody should repeat. Okay. All of you understood, my dear friends? Where is this now? Okay. अरे भाई वर्क नहीं हो रहा यार. The descending palatine artery. Sphenopalatine artery. Bakwas. Elevator. Now you see here, this is the pterygoid wedge. All of you see here. This is pterygoid wedge, okay? Now, as I do here, this is a lateral pterygoid plate, okay? Now, when I go here, you will find the median nerve. This is the median canal. I'll show you that. Here will be the palatovaginal canal function. See here. This is pterygoid wedge. Yes, sir. I'm just going to cut the sphenopalatine artery. Push it laterally. So you can see here the V2. That's the improvital nerve here. Now, elevator. For tuck. See if I can remove it. I'm almost done. Just a minute. Just for you to see the last part. Somebody asked me, show me V2, show me V3, show me V3. I'll show you the V3 and V2 and I'll close it. No problem. You come to our center, we see every day V2 and V3. You should come. If you want to apply for residency, just ask Soumya. We are taking now residency. I'm just going to take this out. Inadequate, inappropriate instrument. That is the reason. Yeah, obstruction. Now you can see here that's the median canal. I know where the median canal is. I'm going to show you that. Can you see the median now here, my dear friends? Wait. See. Can you see the canal? Yes or no? That's the median. Give me a sickle line. Now I'll show you the V2. I showed you that median here. I'm going to show you the V2 there. V2 will be here at 60 degrees. Putting it here. All this. Okay, this is our inferior orbital fissure. This is our inferior orbital fissure. So if that is the inferior orbital fissure, okay, now there's a little variation here. I'll show you. So this should be the V2 and this is the median. You can see here. It is not at 60 degree. I was expecting it at 60 degree, which is actually the usual angulation. See here. See here. Can you see this? It is more than 60 degree. Can you see here? It is like, 75 degrees. See the median and the V2. Can you all see that clearly now? This is median. Actually, it should come like this here. But here, what has happened is, this is median. See the angulation. Almost flat. It should actually be here. See, these are all variations. Now you saw the V2, foramen rotatum, you saw the median. I'll show you the V3. Now you see the V3. See here. So what is this? This is the lateral pterygoid muscle. Okay. This is the lateral pterygoid muscle, right? I'm going underneath the infratemporal surface of greater wing of sphenoid. Okay. Suction. That's V3. Suction. Now, see, I'm going to show you underneath. This is the extra cranial part of the V3. Can you see the foramen there? Yeah, sorry. See here. Can you see the canal there, my dear friends? Here. Can you see? Coming there. This is the V3. Can you see? V3 is this one. This is V3. This is V2. This is median. And the palatopharyngeal canal, according to me, in this case, will be somewhere here. This is the pterygosphenoid synchondrosis. So this will be the palatovaginal canal. So palatovaginal canal, median, V2, V3. V3. Okay, right. Thank you very much, my dear friends. V3. Everybody asked, okay, V3. You're all three. Thank you. I hope you enjoyed the dissection, learned something. So just go and practice the same thing in your cadaver. Okay? Treat the cadaver like God. Very, very important. We have, whenever I do abroad, we call it the silent mentor. So we pray, we touch the feet, then only we start. This is how we treat cadavers. Don't treat it like a. Okay, thank you. Soumya, நீ அந்த சைடு போ. நான் கால் அலம்பிட்டு வந்துடுறேன். வாஷ் பண்ணி. Okay, you can go and start your dissection. You have a wash for my leg somewhere. Any washroom you have? स्लीपर है क्या? कोई भी स्लीपर दो ये.